Hello, everyone. My name is Travis. I'm a second year general surgery resident. I'm about to be third year here at Northside Medical Center. Um, we're affiliated with Western Reserve Health Education, multiple residency programs here at Northside. Um, my lecture today is going to be on gallbladder and biliary disease. Again, like all these basic science lectures, they're all geared toward your shelf exam. Try to hit the high yield points. Not necessarily for the general surgery residency, but for your actual surgery shelf exam. So we'll go ahead and get started. So first, just some gallbladder anatomy, just basics. It's a pear-shaped organ. It's divided into four areas, and these are important surgically as well. So it's divided into the fundus, the body, infundibulum, and the neck. And it gets progressively narrower as you get toward the neck. Some histology. It lacks a muscularis mucosa and submucosa, which is kind of unique. The rest of the GI system has a muscularis mucosa and submucosa. That's where like the dermal lymphatics and the blood supply goes. So the blood supply, this is also very important as far as the surgical aspect goes. If you think of it embryologically, the embryologic foregut is supplied by the celiac trunk, and we'll have a picture in a minute of all the branches of the celiac trunk. These are well vascularized areas and have multiple anastomoses for the organs of the embryologic foregut. So for the gallbladder itself, so you have the celiac trunk, then you have the common hepatic artery comes off. It branches in the hepatic artery proper into the right hepatic, and then 90% of the time the cystic artery is a branch of the right hepatic artery, and that's important for a cholecystectomy. For those of you that will scrub a gallbladder case, you'll hear us talk about the cystohepatic triangle of Collot and its importance in defining anatomy, and we'll go over that in just a second as well. So here, just a little closer look at the anatomy. You see a fundus, and it gets narrow as you get closer to the cystic duct, and obviously this is where the stones get obstructed. And you see where the cystic duct meets the common hepatic duct to form the common bile duct, and then it eventually drains it through the second portion, or into the second portion of the duodenum, sorry. This is another view kind of the inferior border of the liver, like the gallbladder fossa is what we call it, and kind of its relation to all the major structures, and why just a basic cholecystectomy is not just a basic surgery. You can damage some very important structures, including the pancreas, the common bile duct, and the blood supply to the liver. So arterial supply, what I talked about just a minute ago, that's derived from the celiac trunk. You can see that the three branches of the celiac trunk, you have the left gastric, the splenic, and then you have the common hepatic artery. As you can see, the stomach is obviously well vascularized with the left gastric and the short gastrics, and then the epiploic arteries as well. And then you see the common hepatic artery branches into the GDA, the gastroduodenal artery, and that continues up, eventually giving off the cystic artery to the gallbladder. These are just kind of little anatomy questions. They're not necessarily going to get asked on your exam, but they do come up in your surgery rotation and in the OR. So this is the triangle of Collot, which I spoke about just a minute ago. This is a triangular area that is used to identify important structures during a cholecystectomy. So the triangle itself is formed by the inferior border of the liver, the common hepatic duct medially, and the cystic duct laterally. So a majority of the time within this triangle you will find the cystic artery. So that's why this triangle is important during a case. So obviously it's not as easy as this diagram here, but what you dissect lateral to medial from the cystic duct, working yourself medial, you need to know that in this triangle the cystic artery is lying in there, and you have to be very, very careful. and you'll hear us talk about the critical view of safety, which to us means you visualize the cystic duct going into the gallbladder, the cystic artery going into the gallbladder, with no posterior structures that you may miss. So just some quick physiology. We'll go through this pretty quickly. Obviously, the gallbladder does not produce the bile; it just stores it. The primary bile salts, they're synthesized from cholesterol. They're conjugated to make bile acids. You guys have to kind of think back to step one. So I think there's taurine and glycine is what gets conjugated to make the bile acids. That's always just a little tidbit that is easily testable. Obviously, bile is important for the absorption of fat-soluble vitamins. Just think about the fat-soluble vitamins that you need and why they're important. CCK, CCK is an important GI hormone that causes contraction of the gallbladder, but it also subsequently causes relaxation of the sphincter of Oddi, so the bile can drain into the small bowel for reabsorb or for digestion of fats. And then the bile itself is reabsorbed in the terminal ileum via enterohepatic circulation, and this will be important later on down the line when I talk about terminal ileal diseases. And then obviously, gallstones are very common. So you have cholesterol and pigmented stones. We don't get into too much the black and brown stones, which are more in the eastern countries. So first, I'll do this kind of a case-by-case thing. I'll describe a case, and then we'll kind of work our way through it, trying to get your thought process rolling about how you would approach these patients and kind of what you want to do as far as imaging and labs and physical exam. So first case, 42-year-old female, recently underwent CT of her abdomen. She was referred to a surgeon for gallstones. She's asymptomatic and denies any episodes of pain. She denies nausea, vomiting, diarrhea, dark urine, and pale stools. She denies fever and chills. So just kind of think about what additional information you want to obtain, what's important about her history and physical, and what kind of physical exam, maneuvers you'd like to perform. And then again, kind of as an adjunct, what kind of labs and diagnostics would you want to order as well? So we'll kind of work our way through it. Just keep those in the back of your mind, and if you approach these clinically, and it's much different in real life. So cholelithiasis, another word just for gallstones. It's very prevalent. This is 11 to 36%. I actually think it's probably higher than that. Vast majority remain asymptomatic. However, 3% of asymptomatic patients become symptomatic per year. Like I said, this is a very common problem. Risk factors, and we all know the mnemonics. So women are 3 times more likely obese, multiple kids, people on TPN. When I was a medical student, I really didn't know what the hell TPN was. So it's total parenteral nutrition. It's basically just sugars, fats, proteins, and other nutrients through IV. So it's IV nutrition. So if you think about, why would you get gallstones from someone that's on TPN? Well, your gallbladder is not really contracting. It's not getting stimulated by food in your mouth and to your stomach. So you're not releasing CCK. You're not getting any stimulus from, PO intake. So you get kind of gallbladder stasis and then sludge, and this eventually will form stones. So that's the rationale behind that. Oral contraceptives, is pretty self-explanatory. Rapid weight loss, again, that's kind of dealing with gallbladder stasis. Age, obviously, the older you are, the more likelihood you're going to have stones. And then Crohn's disease and terminal ileum resection. What we just talked about, the bile is reabsorbed in the terminal ileum, so you're more prone to stones if you have disease there. So the picture here is a typical gallbladder ultrasound or right upper quadrant ultrasound. You see a uniformly shaped gallbladder wall. It's not very edematous or thick. You don't see any surrounding edema or black fluid, which is called pericholecystic fluid. But you do see a very prominent radio-opaque stone. and then you can describe it as with posterior shadowing behind the stone. So this is just kind of a not necessarily a normal right upper quadrant ultrasound, but it doesn't show any radiographical signs of acute cholecystitis. So treatment for just gallstones, if the patient's asymptomatic, they're not having any issues with their diet or bowel movements or pain, you can just treat these conservatively until they become symptomatic. Just because you have gallstones doesn't mean you have to take their gallbladder out. A prophylactic cholecystectomy is rarely indicated except for these very specific subset population listed here. So, but however, if they do become symptomatic, this changes things. This is when a gallstone obstructs the cystic duct, and then the gallbladder is contracting against an obstruction, which causes pain. So then what happens is the patients will complain of episodic sharp pain with radiation to the back or flank. There's no inflammatory process or no infectious process. They're not usually, fevers, chills, and infection count, suggestive of like acute cholecystitis or cholangitis. But this is an indication to take their gallbladder out if they become symptomatic. Cholelithiasis, it's $1 million word just for gallstones in your common bile duct. This is found in 6 to 12% of the patients with gallstones. In the Western Hemisphere, which is where we are, stones from the gallbladder, the most common cause of cholelithiasis is stones from the gallbladder that migrate into the common bile duct. But if you're from the Eastern Hemisphere, it's a little bit different. So clinical manifestations, again, they can be asymptomatic or they can range all the way to the extreme of cholangitis. They typically have colic-type pain because it's contracting against an obstruction, pale stools and dark urine and icterus. So, think about the physiology behind it. Why would you get pale stools? So, bilirubin and bile goes into the small bowel and then eventually gets broken down into stercobilin in the colon, which causes your stools to be a brown color. But if the bile can't escape into the small bowel because of a obstruction of the common bile duct, it gets backed up into the system and not into the stool. So then you have kind of clay-colored or pale stools, which will sometimes freak the patient out. And the dark urine, again, there's an obstruction. The bile isn't flowing into the GI system, so it's backed up into the circulatory system. It gets spilled by the kidneys, and patients will complain of tea-colored urine. So that's another question to ask, an important question to ask in your history and physical. And obviously they'll be jaundiced. So in physical exam, kind of a place you can look for jaundice, obviously the eyes, but you can also look at underneath their tongue, which I really didn't find out till residency, but I've seen it and it's actually pretty prominent. So some diagnostics and stuff you want to order for someone suspected, cholelithiasis. You want to get some labs. You want to get bilirubin. You want to get maybe a direct and indirect bilirubin just to make sure it's an obstructive process and not some type of hemolytic process. LFTs, amylase and lipase is also important too, just to rule out, pancreatic issues and gallstone pancreatitis, which we'll go over later. Another important point I like to make too, especially for med students going into step 2, they ask you about diagnostic tests and what's a good first test to order, what's a good first lab. They always want to ask what do you want to do first. So someone that comes in with right upper quadrant pain and jaundice, the best first test to do is a right upper quadrant ultrasound. So why first? Well, it's cheap, it's quick, relatively easy, and it's very sensitive. So those are all qualities of a good screening tool. So right upper quadrant ultrasound is a good thing to order first. It can find the stone, it can measure the common bile duct, so it's very sensitive and actually specific too. And then obviously the more information you need, you can get more specific, but these tests are a little more invasive and more expensive. So you can also diagnose cholelithiasis with an MRCP, which is just an MRI of your ducts, and then obviously ERCP, which is I really understood what an ERCP was when I was a med student, but It's essentially an EGD or a scope down the mouth, down into the second portion of the duodenum, and then you can manipulate the bile ducts. So you can get into the ducts, you can clean the ducts out, you can shoot dye through the ducts. So the ERCP is a gold standard for gall stones in the common duct because it's diagnostic and therapeutic. So um, it's invasive, however, so not the first thing you want to do, but it's the definitive gold standard treatment. So step 2 likes to trip you guys up on that. And then complications of ERCP. So if you think about where it's going, so the common duct meets the pancreatic duct at the second portion of the duodenum. So if you're sticking a bunch of instruments and dye up into the common duct, you're also probably shooting stuff into the pancreatic duct, which can cause pancreatitis. So that's one of the most common complications of ERCP. So I just kind of talked about ERCP just a little bit. So you can cannulate the ampulla, you can enlarge the sphincter, allowing passage of the stones, and then you can obviously do a cholangiogram, which means you shoot dye up into the duct and look for any more stones or obstructions or strictures in the biliary system. So treatment for someone with common bile duct stones is to do lap chole, because you have to get rid of the source of the stones, and then you want to do a cholangiogram intra-op. So that means you shoot dye into the biliary system to make sure there's no retained stones, or you can try to flush the stones out so this cholelithiasis doesn't recur. Here's just a graphical depiction of kind of what it looks like, just like a general overview of what an ERCP would look like. So complications of common bile duct stone. So just think about it. So you have a stone obstructing the common bile duct. So the common bile duct, so the bile can't drain into the small intestines, and then it backs up. So obviously the bile is very rich in proteins and nutrients, and this is just kind of a breeding ground for infection. So if there's stasis of the bile in the biliary system, you're going to kind of have a bacterial overgrowth, especially gram-negative bacteria like E. coli, Klebsiella, and this can be a very overwhelming infection called cholangitis. I know you guys talked about Charcot's triad in med school with right upper quadrant pain, fever, and jaundice. It's present 2/3 of the patients, and you kind of have to have a high clinical suspicion of someone with cholangitis. Someone comes in, they're jaundiced, they have 103 fever, and their labs are, especially their LFTs, are all out of whack. I mean, these patients can be very sick and they can decompensate very quickly. So your index of suspicion has to be very high, and these patients need to be treated expeditiously. If Charcot's triad then progresses to Reynolds pentad, which is neurologic deficits and then some type of end organ damage like hypotension and instability, these patients are, their morbidity and mortality is very high. So identifying these patients and getting them aggressively treated is important. So if you get a clinical situation like this on your CS exam, I think you're going to want to do something interventionally, but you kind of have to step back and think about the hemodynamics of the patient. So they come in, their fever of 103, their blood pressure is 80/50, and their heart rate is 130. The first thing you're not going to do, you're not going to take them to do an ERCP. You have to resuscitate this patient. So you have to start IV fluids to try to get their blood pressure up, and you have to start empirically IV antibiotics. That's the first initial management of someone with cholangitis. And then once the patient, hopefully they've stable, then you can kind of progress to more definitive management, which would be, ERCP, so you can decompress the biliary system. So that's something that's very easily testable. I think it's, you have to be able to identify it in a STEM. Next, we have gallstone pancreatitis. So you can imagine, if you remember the anatomy, the common bile duct drains and meets the pancreatic duct at the ampulla levator in the second portion of the duodenum. So sometimes the gall can get lodged there. So what happens is the pancreatic juices cannot get secreted into the duodenum, so they get backed up into the pancreatic duct, and then the pancreas kind of undergoes like some auto-digestion. These enzymes get activated in the pancreas, and it causes pancreatitis. Um, so um, these patients are also very sick. Pancreatitis patients, they're in a lot of pain, they're very sick, and they need to be admitted to the hospital. So the treatment for gallstone pancreatitis, first you have to treat the pancreatitis, which is NPO, nothing by mouth, aggressive IV fluid hydration, and pain control. And then once their pancreatitis starts to improve, their pain improves, their amylase lipase are starting to trend down, then you kind of have to get rid of the source of gallstones, which is your gallbladder. So on the same admission, it's prudent to take out their gallbladder on the same admission. So next case, this is a 46-year-old female. She presents to Northside complaining of nausea, vomiting, and persistent abdominal pain for 24 hours. The pain's localized under her ribs. It's sharp, constant. She hasn't been able to eat, and this pain has been associated with fevers and chills. So again, kind of think about in your mind differential diagnoses and kind of how you want to work this patient up. So in my mind, my 46-year-old female, she's 40, she's female, she's got pain in the right upper quadrant, associated with fevers and chills. I would definitely want to assess her for any type of jaundice. I'd feel on her abdomen. I would do a Murphy sign, which, I would like for you guys to be able to describe what a Murphy sign is, to describe the physical exam of performing that. In our discussion topics, we'll go over that. And then kind of the labs and diagnostics that we talked about earlier. What's the first test you want to order? It's a right upper quadrant ultrasound. I'm going to keep harping on that because I know when you guys get into the test, you're going to see CAT scan or MRI, and you guys are like, "Oh man, that sounds really nice. Let's pick that." But that's not the case. So let's talk about acute cholecystitis. It's acute inflammation of the gallbladder. Over 90% of the time, this is secondary to a gallstone obstructing the cystic duct. So there's a kind of a progression to this as well. You have obstruction, then you have biliary stasis. Stasis causes distension of the gallbladder, and inflammation, and edema of the wall. And then you have kind of bacterial overgrowth. It's just kind of a vicious cycle. So clinical manifestations, kind of what we talked about in that stem. Unremitting pain in the right upper quadrant, may radiate to the back. Patients usually anorexic, nausea, vomiting. These patients are pretty sick. Focal tenderness in the right upper quadrant, and again, what a Murphy sign is. So a Murphy sign is arrest of inspiration on deep palpation of the right upper quadrant. And it's usually pretty obvious when a Murphy's is positive. So again, diagnostics, ultrasound's the most useful. It's 95% sensitive and specific. It'll show stones, thickening of the wall, and pericholecystic fluid. So if you look on the ultrasound, actually it's on the next slide. We'll look at the ultrasound findings of acute cholecystitis. So again, like what I talked about, there's the first test you want to order, and there's the gold standard test which you want to order. So ultrasound is a great first test because it's highly sensitive and specific. But what's the gold standard for diagnosing acute cholecystitis? That's a HIDA scan. So for those of you that don't know how a HIDA scan works, which I didn't know for a long time, you inject dye intravenously, and this dye gets taken up into the liver and then eventually secreted into the biliary system, and then eventually drains into the small bowel. So it really lights up the biliary system really well. So what happens is if there's an obstruction of the cystic duct, this dye is not going to fill the gallbladder. So you'll see the nice right hepatic and left hepatic, common hepatic ducts. It'll come down, and you'll see the common duct, but you may see a short cystic duct, but you don't see any dye in the gallbladder. So that would be considered a positive HIDA scan. There's lack of filling of the gallbladder, meaning there's an obstruction there. So they're actually really nice pictures, and I have one over the next couple slides. So this is an ultrasound of someone with acute cholecystitis. You can see, if you guys remember from the previous ultrasound I showed a couple slides ago, how the wall was nice and uniform and thin. You can see this wall is thick, dilated. It has some kind of a black ring around it, which is pericholecystic fluid, and then it has stones, because you can see the stones inside the lumen with posterior shadowing. So, and you guys always want to take a look out for in the acute cholecystitis. Here's another picture of acute cholecystitis. This is a better picture of like what pericholecystic fluid looks like, where the arrows are. It's just kind of edema of the wall, and you know that it's infected. So this is what a picture of a normal HIDA scan looks like. So the dye gets taken up in the liver. You can go ahead and see a faint outline of what the liver looks like. And then the intrahepatic bile ducts. You can kind of see the right and left hepatic ducts forming the common hepatic, and then you can see with the gallbladder, it looks like that pear-shaped organ, and then the common bile duct lights up as well. So this is a normal HIDA scan, so there's no obstruction in the cystic duct because there's dye that reaches the gallbladder. And then very faintly, you can, if you trace from the common bile duct down, the dye is starting to fill the small bowel, and that's kind of a completion of the HIDA, knowing that the dye has made it to the small bowel. So treatment, again, acute cholecystitis, you don't rush them to the OR right away. You want to resuscitate the patient. You want to give them fluids. You want to give them antibiotics. Usually a third-generation cephalosporin or a second-generation plus metronidazole or flagyl. Pain control, and then you want to take their gallbladder out within 2 or 3 days. Once they're resuscitated, they've got antibiotics. It needs to come out the same admission. A percutaneous cholecystostomy tube. Again, these patients are usually super sick, and they can't undergo general anesthesia, get intubated. So what happens is interventional radiology will stick a catheter via CAT scan into the gallbladder to drain it. They'll decompress the gallbladder without actually having to undergo general anesthesia. So we'll go over that in a little bit. So here's a question. Let you guys read it over and think about it for a minute. So, we just went over this, so I know. So what's the gold standard to make the diagnosis? So what do you think she has? 46-year-old female. She's obviously gravid. She's got pain under her ribs, fevers and chills. And what is the physical exam finding they're describing? They're describing a Murphy's, right? So it sounds like she has acute cholecystitis. So what's the gold standard for diagnosing acute cholecystitis? It's not CT scan. It's not an ultrasound. So it's scintigraphy scan, which is another name for a HIDA scan. So kind of tricky. Probably not a fair question, but just aware that the gold standard is a HIDA scan. So here's some other biliary disorders. Acalculous cholecystitis, which is exactly what it says. It's inflammation of the gallbladder without gallstones. These patients are usually super sick, multiple issues in the ICU. They're patients on TPN, severe burn patients, septic patients. This is usually the patients are intubated and sedated, and they, if you palpate their abdomen, they may grimace to pain in the right upper quadrant. So again, the diagnosis is the same. You'll do an ultrasound, and sometimes you may catch it incidentally on a CAT scan when you CAT scan for another reason. But again, CAT scan is not the test of choice for acute cholecystitis. So again, the treatment for these people is a percutaneous cholecystostomy. We call it a chole-Foley, just to decompress the gallbladder, because these are not fit for surgery. Emphysematous cholecystitis, this is caused by some pretty nasty bugs. These are caused by Clostridium perfringens, and these are usually in raging diabetic patients. You can see this is air within the gallbladder wall, which isn't supposed to be there. So that's an emphysematous gallbladder. It needs to come out. Porcelain gallbladder, luckily this is rare because it's a premalignant condition. These are severely calcified gallbladders. Not really much more to it. Just these are pre-malignant, they need to come out, so it's an indication for surgery. Gallstone ileus. This is luckily pretty rare as well. This is when a pretty large gallstone will kind of erode through the wall of the gallbladder, and will kind of work its way into the bowels, and usually into the small, um, and then the gallstone will kind of roll and tumble till it gets to the ileocecal valve, and it'll just get stuck there. So what happens is it causes a mechanical obstruction, um, proximally. So you have a big stone at the ileocecal valve, anything from the small bowel obstructed, so everything proximally is getting dilated. You'll see air fluid levels on an x-ray, and then you may see even like a radiopaque stone on the x-ray as well. So like I said, these usually get stuck at the terminal ileum, and you'll see pneumobilia within the biliary system, which isn't normal. So this is pretty rare, luckily. This is just a CAT scan of what a porcelain gallbladder looks like. It's just heavily calcified. So gallbladder carcinoma, it's pretty rare, luckily, because the 5-year survival rate is only percent. Risk factors, not everyone that has gallstones gets gallbladder carcinoma, but it is a risk factor. And then obviously the porcelain gallbladder is a risk factor as well. Majority are adenocarcinoma. Most of the time this is found incidentally after a cholecystectomy. The treatment, again, this is kind of gets into details for mostly just for surgery residents. The treatment is usually just surgery, depending on how far the carcinoma is eroded into the liver. You may have to do a liver wedge resection if it's eroded into the liver, but usually it's take the gallbladder out and then stents is just palliative because, again, the survival rate's very low for these. Cholangiocarcinoma, they love asking questions about this just because of its risk factors and kind of how they present. So 2/3 are located at the bifurcation of the hepatic duct. The risk factors, so primary sclerosing cholangitis, that's kind of like in skinning, like the stricture and dilation of the biliary tracts. Ulcerative colitis is another risk factor for cholangiocarcinoma, and then Clonorchis, worm infection. So all the C's, you can see PSC, UC, and Clonorchis for cholangiocarcinoma. These are all risk factors. Presentation, painless jaundice. So if you think about like a stricture and you see your PSC, it's not very painful. It's not like it's not cholangitis. It is causing biliary obstruction, which is why they're jaundiced. And a lot of times people that are jaundiced and have hyperbilirubinemia, they'll be very itchy. They'll describe like that's one of their worst complaints, is them being very itchy. So that's pruritus. And they're not very hungry as well. They're anorexic. So treatment, again, is surgery. You can stent. Again, this is all just palliative because the survival rate's very low. So another question, 42-year-old lady, she's jaundiced, total bilirubin of 6. The lab reports the unconjugated indirect bilirubin is 6, and the direct conjugated bilirubin is 0. She has no bile in the urine. What's the most likely diagnosis? So, memorizing lab values is hard when you're a med student. Once you see it more in residency, you get more familiar with it. So normal bilirubin is less than 1, and that's just that's a total bilirubin. So this patient's bilirubin is 6, and on top of that is an indirect bilirubin. So it's indirect or unconjugated. So what are some causes of that? So this isn't an obstruction, right? This is something going on with hemolysis. So this isn't because of gallstones or CBD stones or cholecystitis. This is because of spherocytosis. So this patient is having massive hemolysis causing the liver just can't catch up. It can't conjugate the bilirubin fast enough because of the hemolysis. So that's why the unconjugated is high. So next question. I'm not going to read it, and you guys can read through it. I'll talk to it in just a second. Pretty straightforward. I'm 40-year-old, obese, gravid, She's got jaundice. She has a conjugated or direct hyperbilirubinemia. Alk phos is high. History is positive for right upper quadrant pain. What diagnostic imaging study is recommended first? I've went over this several times. It's an ultrasound. It's quick, it's easy, it's cheap, it's sensitive, and it's specific. So, all right, I think this is the last question. 40-year-old female presents with severe epigastric pain radiating to her back. The pain appeared suddenly, associated with nausea, vomiting, and yellowing of her eyes. She has an elevated amylase and lipase. An ultrasound reveals stones in the gallbladder. Which of the following is the appropriate course of treatment? So there's a lot going on here. So she's got 48, she's female, she has epigastric pain radiating to her back, she's jaundiced, and she has gallstones and an elevated amylase lipase. So what does this sound like? So to me, it sounds like she has pancreatitis because of the epigastric pain, elevated amylase lipase. So there's many causes of pancreatitis, and I guess number one cause of pancreatitis is alcohol. But in this case, that's not part of the history. But number two, most common cause of pancreatitis is gallstones. So it sounds she's confirmed to have gallstones on ultrasound, so she most likely has gallstone pancreatitis. So first, that's the most important part, kind of working your way through the diagnosis and then figuring out the treatment options. So in gallstone pancreatitis, first you want to treat the pancreatitis, which is NPO and IV fluids and pain management. But you have to take out the source of the gallbladder, the gallstones, so then it would proceed to a cholecystectomy. However, because she's jaundiced, she has some type of obstruction as well, right? So she's yellowing of her eyes, so she probably has a common bile duct stone as well. So I think she's going to need an ERCP first before she has a cholecystectomy. So the first answer choice. So NPO IV fluids to treat the pancreatitis. Once that cools down and calms down, her pancreatitis and her pain improves, she'll need an ERCP to clear the common duct, diagnose any other gallstones she has in the common bile duct, and then eventually get rid of the source of the stones, which is the gallbladder. So